Senior Managers on the Guideline Development and Research team. Presenting with me today, we are delighted to have one of the co-chairs from the expert panel, Dr. Katarina Matursky, who has provided extensive support, guidance, and insight throughout the development of this guideline. Our second co-chair, Mike Creek, is unfortunately unable to make it today, but we would like to acknowledge his extensive contribution to the guideline as well. You will also hear from other members of the RNAO team today who were involved in supporting the development, implementation, and evaluation of this guideline, including Nicole Graham, who is a guideline development methodologist and implementation science manager, Catherine Wallace, who is senior manager from the implementation science team, James Oliveira, who is our indicator developer, and Anam Ali, who is the evaluation specialist. For today's session, we will discuss people-centered care and why implementation of this guideline will be invaluable for improving the quality of care we provide to people. We will then discuss some key steps for kickstarting implementation and evaluation of this guideline in practice settings. And as Verity mentioned, there will be some time at the end for questions, and we'll reserve those to the very end. So I'm going to hand it over now to Nicole to start off today's presentation. She's going to be sharing a little bit about the Registered Nurses Association of Ontario and the International Affairs Best Practice Guideline Program. So I'll hand it over to you, Nicole.
Thank you, Julia. So I'll just start with who we are. Established in 1925, the RNAO has a long-standing history of championing healthy public policy, supporting excellence in nursing practice, and amplifying nurses' voices in shaping Ontario's health system. The RNAO is the professional association representing over 54,400 registered nurses, nurse practitioners, and nursing students in Ontario. We're the strong, credible voice that leads the nursing profession to influence and promote healthy public policy and clinical excellence. A signature program of the RNAO is the International Affairs and Best Practice Guidelines Center, which houses the Best Practice Guidelines program. The RNAO's Best Practice Guidelines are actively implemented across Canada as well as internationally through partnership with our over 1,500 Best Practice Spotlight organizations worldwide. The Healthy Public Policy Program is another core pillar of RNAO. It advocates for evidence-based policies to improve health outcomes and strengthen nursing profession. It focuses on key issues like health system transformation, workforce sustainability, and social determinants of health. Next slide, please. So launched in 1999 and funded by the Government of Ontario, the RNAO Best Guideline Program is dedicated to developing, disseminating, and actively supporting the uptake and sustainability of evidence-based clinical health work environment and health system BPGs. The program has also evaluated their impact in patient and organizational and health system outcomes. Currently, our library has over 50 best practice guidelines, complemented by a range of implementation toolkits designed to facilitate effective and sustainable integration into practice. On this slide, you'll see the RNAO's Integrated Best Practice Guidelines model, which is built on 3 interconnected pillars: guideline development, guideline dissemination, implementation and sustainability, and guideline monitoring, evaluation, and research. These pillars are interdependent and work in harmony to enhance outcomes for individuals receiving care, care providers, organizations, and health systems. Throughout this webinar, we will explore each of these pillars in the context of developing, implementing, and evaluating the people-centered care BPG. We'd also like to highlight again the RNAO's Best Practice Spotlight Organization Program, which was launched in 2003. The BPSO program has, as I said, over 1,500 BPSOs in Ontario, Canada, and internationally, with numbers continuing to grow as new countries are added to the global BPSO network. This slide demonstrates the QR code that links the RNAO's BPSO geospatial map, which you can access. You can find all of the BPSOs, the guidelines they are implementing, and how to connect with these leads. Thank you. On this slide, you'll see a visual representation of RNAO's guideline development pillar, which outlines the 6 key steps in our guideline development process. So we begin by selecting a guideline topic, which may be informed by emerging priorities in public discourse or identified needs from our partnered best practice spotlight organizations. Next, we convene an expert panel. This panel is internationally diverse and interprofessional, with representation from various sectors, including clinical practice, research, education, and administration. Importantly, it also includes individuals with lived experiences, either as patients or caregivers, which are related to the guideline topic. Once a panel is assembled and the recommendation areas are prioritized, our guideline development and research team conducts systematic reviews to gather and analyze the best available evidence. Based on this evidence, the team drafts a recommendation statement, which are then reviewed, discussed, and refined by the expert panel until consensus is reached. Following this process, the RNAO will draft the full best practice guideline and circulate it to expert panel for review. The guideline then undergoes external review, where relevant stakeholders and practitioners provide feedback. This input is incorporated into the final version, which is subsequently reviewed internally before being sent for editing, design, and printing. Finally, the BPG is published online and dissemination activities are initiated to support its uptake. And this webinar is an example of one of those. The RNAO strives for a 5-year revision cycle to ensure that these guidelines stay current. Next slide, please. Thank you. So as we introduce the 3rd edition of the People-Centered Care, BPG, one of the key updates in this 3rd edition is the shift in terminology from person and family-centered care to people-centered care. This change aligns with the World Health Organization's language and was endorsed by both the expert panel and the external reviewers. The term people-centered care moves beyond labels like patient or client, which can imply passivity or transactional relationships. Instead, it reflects a more inclusive and empowering approach that acknowledges the essential roles of individuals, caregivers, chosen families, communities, and cultural contexts in health and healing. This slide presents the definition of people-centered care as outlined in this guideline. It's defined as an approach to care that consciously adopts the perspectives of individuals, families, and communities, recognizing them as participants and beneficiaries of trusted health systems that respond to their needs and preferences in humane and holistic ways. And this is in reference to the World Health Organization 2024. This definition emphasizes the health needs and expectations of individuals seeking care, as well as those families and caregivers, communities, and societies. It highlights that everyone involved in a person's care plays a pivotal role in delivering meaningful and responsive services. So people-centered care is a globally recognized cornerstone in high-quality health services. By aligning care with individual needs, values, and preferences, it leads to better health outcomes, greater satisfaction, and stronger engagement in care. When care is delivered with respect and active listening, it fosters informed decision-making, adherence to care plans, and meaningful participation in one's health journey. People-centered care delivers clear evidence-based benefits. It reduces hospital admissions, shortens stays, lowers mortality, and cuts down on unplanned visits. At the same time, it improves quality of life and helps reduce overall costs. Strategically, it's a key driver of the quintuple aim and essential to sustaining long-term improvements in our health system. So I'll now pass it over to Julia Zuckel to present more details about the 3rd edition People-Centered Care BPG. Thank you.
Thanks, Nicole. Before we move into a closer look at the guideline, I would just like to mention that this guideline would not have been possible without the invaluable contributions of our expert panel. The panel comprised individuals with lived experience and a diverse range of expertise spanning clinical practice, education, research, and policy, and really represented voices from across health and social service sectors, academic institutions, and practice areas. In addition, the draft guideline was reviewed by external stakeholders, 149 reviewers to be precise, from Canada and internationally, and their perspectives further strengthen the rigor and relevance of this resource. And if you want to take a look at who was the full list of expert panel members, as well as the full list of external reviewers, you could take a look in the guideline for that. And of course, I'd like to acknowledge the entire RNAO team that was involved in bringing this guideline to life as well. And we have a long list here of everyone involved. Okay, so to review the purpose and scope of the People-Centered Care Best Practice Guideline, the purpose is really to promote the evidence-based, cultural, and equitable practices that are associated with people-centered care, and to help health and social service providers acquire the knowledge, skills, and judgment necessary to become more adept with people-centered care. And it's important to acknowledge that the guideline is for all nurses and all other members of the interprofessional team that work in all domains of practice and in all health and social service settings. And the guideline is for all people across the lifespan, including caregivers, families, and communities. So when we develop our guidelines, we use the grading of recommendations, assessment, development, and evaluation method to support the rigorous guideline development process. So GRADE is in line with international guideline standards, and it is used by other large organizations such as the World Health Organization or NICE organization in the UK. As you're reading the guideline, you'll notice that it contains both good practice statements and recommendations. So I'm going to walk through the difference between these two statements. But what is really important to remember is that they're both action-oriented statements that are based on evidence that make the guideline something that can be implemented. So whether it's a good practice statement or whether it's a recommendation, they follow the exact same process for implementation. So good practice statements, and you'll see that listed on the left-hand side of the screen, are actions that must be done in practice. They may be seen as so common sense, but they are not always actually happening in practice. So it's important to reinforce them in the guideline. We have high certainty that the benefits of the action far outweigh any harms, and a systematic review is therefore not needed to determine this. In addition, researchers may no longer be conducting studies on the topic as the benefits are so well known, or it could be that the alternative may actually be unethical, so it would not make sense to study it. Good practice statements do not receive a rating of strong or conditional, but they should nevertheless be interpreted as a strong recommendation. So an example of a good practice statement would be conducting an assessment before carrying out any type of intervention. Recommendations, on the other hand, are also action-oriented statements, but they're developed based on evidence from a systematic review. So they, in fact, answer a research question about whether an action or intervention should or should not be done. They're determined to be either strong or conditional by considering the benefits and harms of the action, how certain we are in the evidence, the values and preferences of people, and the impact that they might have on health equity. So in the following slide, we'll talk a little bit more about strong and conditional recommendations and the differences between the two. Again, what is most important to remember is that both statements, so good practice statements and recommendations, reflect best practices and should follow the same process for implementation. So again, the current slide gives you a little bit more detail to help you differentiate between a strong versus a conditional recommendation. And as mentioned before, good quality evidence typically leads to a strong recommendation. So GRADE only considers randomized controlled trials or systematic reviews as high quality evidence which may equate to a strong recommendation, depending on their quality and rigor. On the other hand, low or very low quality evidence typically leads to a conditional recommendation. In general, GRADE discourages expert panels from making strong recommendations that are based on low or very low quality evidence. Now, when we say that a recommendation is strong, it implies that there is a high quality evidence to support the recommendation, that the desirable consequences outweigh the undesirable ones in most settings, and that most people will benefit from the recommended course of action. When we say that a recommendation is conditional, it implies that there is low quality evidence to support the recommendation. The desirable consequences probably outweigh the undesirable ones, but because we have low certainty evidence, we can't be 100% certain. And many people will benefit from the recommended course of action, but many, again, may not benefit from it. So conditional recommendations really they're not bad or less important. There's just a need to consider more carefully than usual if an individual patient's circumstances, preferences, and values would benefit from the recommended practice. And what you see on this slide is a simplified PRISMA flowchart. And this basically just indicates the rigorous process for the systematic reviews that the RNAO guideline development team conducted for each of the 2 recommendation questions. So our systematic reviews were aided with the help of a health science librarian from the University Health Network. And the searches were conducted in 2023 and updated again in 2025. And to answer the research questions that informed the recommendations, we screened over 15,000 articles. And of these, 282 were reviewed for full text. We reviewed them for relevance. And then finally, from those 282, 8 articles were included in the final list that informed the recommendations. And each of the included studies were also quality appraised using the appropriate validated tools. And if you're looking for more details about the PRISMA diagrams or our methodology, you could take a look at our methodology documents tab on the website, and I'll show you a screenshot in a few slides of how that looks. So before I pass it over to Dr. Matursky to review the recommendations and good practice statements, I'll provide an overview of how to read the components of the recommendations and good practice statements within the guideline. So for each of the recommendations, you'll see the recommendation box, and this outlines the recommendation statement, the strength of the recommendation, and the certainty of the evidence. The recommendation box is then followed by the discussion of evidence, and the discussion of evidence is divided into 6 different components. So the first component is the benefits and harms. And simply, this is just a section that highlights the desirable and undesirable outcomes that are reported in the literature when the recommended practice is used. The second component is values and preferences, and it highlights the preferences for a recommendation and the value placed on the resulting health outcomes. And this comes from the perspective of the person receiving care. The third component is health equity, and this highlights the impact the recommended practice could have on health outcomes across different populations or settings, as well as any potential barriers to implementing the recommended practice, depending on your practice setting. The fourth component is the expert panel justification of the recommendation. And this provides the reader a rationale for the expert panel's decision regarding the strength of the recommendation. So why was this recommendation considered to be strong versus conditional? Following this, you'll see the fifth component called implementation tips. And this describes the how, the who, where, what, and when related to implementing the recommendation. And this information can come from the evidence from the systematic review or also from the expert panel or external reviewers. And finally, the sixth part of the discussion of evidence is the supporting resources. And this includes relevant resources such as websites or links or tools that are related to the intervention in general. And again, the supporting resources comes from our expert panel or any of the external reviewers. Similarly, for each good practice statement, you'll see a box where the good practice statement is outlined. And the big difference here is really that there is no strength or certainty assigned to the good practice statement because, as I mentioned a few slides previously, these are common sense actions that should be done in practice. And so we don't conduct a systematic review. So following the good practice statement, there's a write-up that outlines any key terminology, why the statement is considered to be good practice. And then this is followed again by implementation tips provided by the expert panel or found in the literature, as well as any supporting resources. So I'll now hand it over to Dr. Maturski to review the recommendations and good practice statements in the third edition of the People-Centered Care Best Practice Guideline.
Thank you so much, Julia. So on this slide, what you can see is that there are 5 good practice statements and 2 recommendations that fall into 5 broad categories in the best practice guideline. These include therapeutic relationships, shared decision-making, plan of care, healthcare environments, sensory minimizing strategies, and virtual care. The summary of recommendations and good practice statements chart can also be found in the best practice guideline. Due to time constraints, we won't be going through all of the good practice statements and recommendations in detail today. However, we encourage you to read them in the published guideline. What I will do now is provide a high-level overview of the recommendations and the good practice statements included in the guideline. Next slide. This good practice statement 1 reads as, it is good practice for health and social service providers to establish and maintain therapeutic relationship with people that is grounded in trauma-informed care and culturally safe practices, ensuring respect, trust, and collaboration. A therapeutic relationship is a fundamental and central component of people-centered care and has been associated with improved outcomes for people and care providers. This good practice statement did not require review of evidence, but it is important to communicate to nurses and other health and social service providers. Within this good practice statement, we outlined the 7 forms of knowledge and 5 capacities providers must possess to establish a therapeutic relationship with people. We also provide several implementation tips, including important tools and resources. For example, the NURSES nurses, wish, worry, wonder, and ask, tell, ask are 3 communication support frameworks that can be adopted when trying to establish a therapeutic relationship. The GDMs also conducted a scoping review that can be found in Appendix D that outlines numerous communication strategies that promote therapeutic relationships. Next slide, please. In terms of shared decision-making, good practice statement 2 reads, it is good practice for health and social service providers to participate in shared decision-making with people as they make informed decisions about their treatment, care, and services. Good practice statement 3 reads, it is good practice for health and social service providers to regularly assess people for readiness for advanced care planning and facilitate the process when ready. And finally, recommendation 1 reads, the expert panel recommends that people are provided with decision aids to enhance participation in making informed decisions related to health screening and healthcare treatment options. At the bottom, you will also see we talk about the strength of the recommendation and certainty of the evidence of effects on the slide. But shared decision-making is a process whereby health and social service providers collaborate with people to make decisions about the person's immediate or future health and care needs. including advanced care planning. The decisions are based on the risks and benefits and possible consequences of various care and treatment options using the best available evidence, in addition to the preferences, needs, beliefs, and values of the informed person. To support the shared decision-making process with respect to health screening and our healthcare treatment options, the expert panel recommends that decision aids be used. Decision aids clearly identify the healthcare decisions to be made, provide evidence-based information regarding the treatment options, provide information on the associated benefits and harms of each option, and elucidate personal values and preferences. Catherine will be speaking a little bit more about how to implement the shared decision-making good practice statement and the decision aid recommendation in a little bit in our webinar today. Next slide, please. In terms of plan of care, the good practice statement 4 reads, it is good practice for health and social service providers to collaboratively develop a plan of care with people that reflects their values, beliefs, goals, needs, attitudes, and preferences. A plan of care is a collaborative, person-centered document used by health and social service providers to support holistic care by reflecting an individual's values, goals, and preferences. It facilitates communication across sectors and includes key elements such as medical history, cultural needs, care team roles, and social determinants of health. Co-created with the individual and their chosen supports, it promotes shared decision-making and enhances engagement in care planning. This good practice statement did not require a review of evidence, but it is important to communicate to nurses and other health and social service providers. Next slide, please. Healthcare environments, sensory minimizing strategies. The recommendation 2 reads, the expert panel suggests that people are provided with eye masks and or earplugs as a sensory minimizing strategy according to the needs and preferences of the person. And as you saw in 2 slides prior, it also has the strength of the recommendation as conditional and certainty of the evidence of effects very low. For this recommendation, we recognize that there are many sensory minimizing strategies that can be used in healthcare settings to decrease potential ambient stressors. However, for feasibility reasons, a decision was made by the GDMs that expert panel members to only focus on eye masks and earplugs as the main sensory minimizing strategies. The implementation's tips section covers important consideration that providers should be aware of when using earplugs and or eye masks. Next slide, please. And for virtual care, the good practice statement 5 reads, where virtual care can be offered as an alternative to in-person care, it is good practice for health and social care providers to determine appropriateness and modality based on people's care needs and preferences and to adjust as needs evolve. Virtual care is an important component of people-centered care, which emphasizes tailoring health and social services to individuals' unique needs and preferences. When virtual care is appropriate, providers should prioritize the modality preferred by the person unless it poses risks such as safety or confidentiality concerns. Various modalities like phone, video, and secure messaging can be used, but all must meet validated standards for privacy and security. Virtual care enhances the continuum of care by improving access, conserving resources, and supporting chronic disease management, and has been associated with positive experiences such as increased comfort and safety, especially during the COVID-19 pandemic. I will now hand it over to Julia to discuss the mapping document and the webpage.
Thanks so much, Katarina. So as you're all likely aware, and as I mentioned a few slides ago, back in 2017, we transitioned to the grade methodology. So therefore, the guideline methodology changed from the previous person and family-centered care BPG, as that one was developed in 2015. And so as you're flipping through this new edition, you'll notice that it might look a little bit different in terms of how the recommendations are presented, as well as the inclusion of good practice statements, which we didn't have previously. So our team has developed what we call a mapping document, and part of this document is visible on the screen here. And really it just outlines any changes or similarities in the third edition guideline compared to that previous edition. So this document can really be useful when implementing the new recommendations from this new edition. And this is where you can locate it. So when you go to the People-Centered Care webpage, you'll see here that there's a tab called Methodology Documents. So if you click on this, you'll find the mapping document as well as any other documents related to our methodology. So whether it's the guideline development process, our grade evidence profile, our PRISMA diagrams, you'll find it all listed there. So at this point in the presentation, I'm actually going to hand it over to Catherine, who's going to be speaking about implementing the People-Centered Care Best Practice Guideline.
Thanks, Julia, and welcome everybody. So happy to have so many of you with us today and the opportunity to talk more about the People-Centered Care BPG and how we can use this to inform our best practices in our settings. So let's talk a little bit more about the implementation and what tips, resources, and strategies we can glean from this BPG. So my objectives here to describe how you as end users of this guideline can start planning your implementation activities, again, using the many tips and resources you'll find in this BPG, and then also to highlight some of the other key actions to kickstart implementation. And as you can see on the graph, we have this integrated BPG model at RNAO. It really is what sets us apart. So in addition to the creation of the best practice guidelines, we have two other pillars that support you as end users to support not only the dissemination of the BPG, which is what we're doing today, which is exciting, and then the implementation and sustainability pillar that really looks at the adoption and integration of this BPG across at the micro, meso, and macro levels. And then finally, the monitoring and evaluation that my colleague will speak to, which allows us to gauge then the impact of people-centered care when we've made these practice changes. Okay, so we're going to look at two of the statements that are in the BPG that were introduced to us by Dr. Matursky. So thank you for her presence today and for highlighting all of the statements that make up this BPG. And my intention here is to chat briefly with you about some of the tips, strategies, resources that are in this BPG that can help us as we start to think about actually implementing this guideline and making practice changes. So we're going to look at Good Practice Statement 2.0 and Recommendation 1.0. So Good Practice 2.0 again focuses on shared decision making. Shared decision-making is something I suspect that for many of you, this is a practice you already are implementing in your various settings. It is, as we learned, a good practice statement, meaning it's something that's well established in the literature and also something that's well established in clinical practice. So it's tempting with all of these good practice statements, including this one, to assume we're already doing this, so there are no practice changes we need to consider. But in fact, there may be some as we read this BPG that can help to further enhance shared decision-making and help to accelerate people-centered care principles. So we'll look on the next slide. Yeah, and so by definition, shared decision-making is a process or an approach to care, one that's ongoing, iterative, collaborative, and values-driven, with a goal then ultimately to support people's active role in making decisions regarding their care needs. And again, at first glance, for many of you, this is something that's already in practice. And yet, if we were to ask staff, what is your approach to shared decision making? And we may find that there are different elements that each staff member are using. So in implementing this BPG, we may find some shared or standardized approaches to shared decision making, recognizing though that the actual shared decision making may look very different from person to person, but still as staff, we have a unified or standardized approach to shared decision making. And this can be important because when we're implementing best practices, one of our goals is to make the practice change visible, observable, tangible, so that it's defensible, so that we can say to the people that we serve, our communities, etc., that we are actually making this best practices, and here is how we do it. We have a way of defining it. So the BPG gives us lots of tips and ideas about how we can make this practice change visible or observable, not with an intention necessarily to be prescriptive, but rather to give us some ideas and then to think about what makes sense in our local context. So again, in the BPG, many sections for each of the good practice statements and recommendations, as Julia has described, and including implementation tips. And again, this can give us some ideas about how do we take these statements, these good practice statements, and actually put them into practice. So again, from this specific recommendation, or the good practice statement rather, a number of implementation tips, including the use of tools, including decision aids, and that's discussed more in recommendation 1.0. So we'll have a look at that together. But also ways in which we can demonstrate shared decision making. We could document consent and participation in shared decision making. So that would be something then that we could show in an observable manner that we have integrated shared decision making. We also might document the discussion of the options with the person, their decisions with that person and or with their decision maker. Again, those can be ways in which we can visibly show that we have adopted this recommendation, the shared good practice statement. We also can find a number of great tools, strategies, tips, resources in the supporting resource section. So again, there are supporting resources for each of the recommendations and good practice statements. So these are a listing of relevant resources. They support the recommendation or good practice statement, and they have each been assessed for relevancy, for credibility, quality, accessibility, meaning they can be accessed with no cost. Sometimes you're required to in, but others can be accessed easily, and timeliness, that they have been published within the past 10 years, or the time in which the last BPG was published in this topic area. They're not meant to be an exhaustive list, so it's not every relevant resource, but the ones that have met the assessment criteria, and their inclusion is not meant as an endorsement from RNAO. In the BPG online, you'll be able to easily, through the links then, find these supporting resources. So for many of us, I know we like to read the print copy of the BPG, but no, the advantage of the online version is that you can easily click and find all of these resources. And again, they give us some ideas about how to implement this good practice statement. So for example, in terms of shared decision making, again, if we were to ask each staff member on our team, what does it mean to you? We might find that each person has a different understanding of what this means. And so the shared approach, for example, is a way of standardizing shared decision making in terms of all of the elements that would be included in that conversation, in that communication strategy to support an individual or a substitute decision maker to be able to make decisions. So again, here is an example of a tool, a resource that could be used to help to standardize this as best practices and enhance the care that likely you are already providing. Similarly, in Appendix I is another model that supports shared decision making. And again, these are concepts that are not new to us, but may give us some more insight into how can we do this in a way that is consistent so that each person is receiving the same supports in terms of shared decision making and processes that can help then with this approach to care. So again, you'll find this in Appendix I. You'll also find in the supporting resources from NICE, the National Institute for Health and Care Excellence. They make guidelines like RNAO, based out of the UK, and similar to RNAO, also are based in international standards. So they're guidelines that you can trust. And they also have some tangible ideas about how shared decision-making can be put into practice. So again, I draw your attention to this just really to get you thinking about all of what's in this guideline. In addition to the summary of evidence is also some great tips that can help us then to put this knowledge into practice. Also, for shared decision-making, it is a concept that we are all very familiar with, but we may want to further enhance capacity in understanding what are all the components of shared decision-making. So again, in this BPG, you will find a link to a tutorial. This is developed from the Ottawa Hospital Research Institute, and it's about shared decision-making. And this one does require a login, but you can see this is a ready-made e-learn that can help then staff to learn some of the concepts associated with shared decision making. And again, this could be something that's helpful just to boost our understanding of shared decision making and how to further enhance this as an approach to care. So lots in this BPG that we can use. So let's look at just some other general tips in terms of kickstarting implementation, then we'll look at recommendation 1.0. So of course, once this guideline is published, in order to put this knowledge into practice, we can't simply just read the guideline and think passively we'll make the practice changes. We need a team in our organizations to be responsible for guiding, leading this process of knowledge translation, of BPG implementation. And typically in organizations, this is a change team that is going to be charged with this responsibility of guiding, leading a change process, ideally with the input of staff, of senior leadership, of the community, the people that are involved in our organizations. And for our change teams, we've got a number of resources at RNAO that can be very helpful to them in the work that they're doing in guiding, leading a change process. So from our Leading Change Toolkit, we have a section called Core Leadership Structures that details some of the roles and responsibilities of our change teams. We also have a presentation as part of our Best Practice Champions Information Sharing series on strategies for teams who lead change, and much of that content is based on the core leadership structures. And then as part of our Best Practice Champions Network, we have a Champions workshop and a curriculum and a number of job aids, and there is a job aid also that is on change teams. So lots of resources that can help our change team who have the role and responsibility of guiding, leading a change initiative. Now, our change team needs to be competent champions. They need to have the know-how to be able to plan, make, and sustain change. And our team has developed our Best Practice Champions competency framework that outlines the roles and responsibilities that champions play in order to be effective in their role. What are the knowledge, skills, attitudes, and behaviors that champions need to have? And you can see that's depicted in the graphic on the left-hand side. And many of these roles are similar to the ones that we may play in terms of clinical practice, but we can also use them in the context of planning, making, and sustaining change. And I'll draw your attention to the content and context expert. A content expert would be somebody who knows how to read a guideline. They know things like the difference between a good practice statement and a recommendation. They know about how to plan, make, and sustain evidence. And a context expert is able to then take a guideline and say, what does this mean for us? So remember, this guideline, like any guideline, isn't written specifically for your organization. There has to be a translation of what does this mean for us? And that's the stuff of a context expert. So again, we need our change team members to have these competencies to be effective in their role, to be able to take a guideline and be able to then implement it into their local setting. So if this is something that is new or newer for you, again, there's a description that we've heard today from Julia in the webinar. There's also a description in the BPG itself. And then also was a presentation done a couple of years ago now on how to read, use, and interpret a best practice guideline. So this is available on the website, and you can find this there. You also can find lots of resources about planning, making, and sustaining change through our Leading Change Toolkit. This was developed for people like yourselves, change agents, change teams, to make lasting improvements in healthcare, and do that in part by using our BPGs. And in our Leading Change Toolkit, it talks about 2 frameworks that you can use for the adoption and integration of best practices. We must get people involved in the change process. And so for that, we have our Social Movement Action Framework and more details on that. And then we also need to know what are the processes we can use to plan, make, and sustain change. And for that, we refer to the Knowledge to Action Framework developed by Dr. Ian Graham and colleagues. Now, in the Leading Change Toolkit, and we have our gap analysis. We talk about a gap analysis. That's the difference between the no-do gap, where we compare what are our current best practices and what does the BPG say. And so we have a gap analysis template for this BPG, and you'll find that on the website in the upcoming days. You'll also find there is a job aid on conducting a gap analysis. If this is new for you, again, this is one of the first responsibilities of our change team. And also in the Leading Change Toolkit, we have a tip sheet on how to complete the gap analysis and do it in a way that can really help us to determine the gaps and also determine priorities for next steps. All right, so beyond this then, let's look at recommendation 1.0. This one is focusing on providing people with decision aids, and this can be linked to that good practice statement 2.0 about shared decision making. So sometimes we're using a decision aid to support that shared decision making, and this is what recommendation 1.0 is focused on. And again, as before with the good practice statement, there are many tips, ideas, resources, strategies that can help us to be able to implement this recommendation on providing people with decision aids. So again, we have implementation tips that'll help us to start thinking about actually using these at the point of care. And some important tips, particularly this first one that says that the PDA, again, a patient decision aid, it never replaces the provider's role of facilitating shared decision making. It can always be tempting when we have a resource, a tool, to think that it will do the heavy lifting for us. But no, as the providers, we still have a key role in facilitating shared decision making and using the patient decision aid as a tool for that. We also need to find PDAs, and again, the guideline gives us some guidance regarding that. Also determining as an organization when we'll use them, when we won't, the timing of them, to understand that when we first use them and use them with persons, that sometimes takes more time initially, but then can help in terms of improved outcomes. And we need to build some capacity in using PDAs as a tool to support shared decision making. So in terms of finding a PDA, there are 2 sources that the BPG recognizes as having databases of quality PDAs. One is the Ottawa Hospital Research Institute, and here I've just got a screenshot, and again, all of this is linked in the online version of the BPG of an A to Z alphabetical listing of decision aids by health topics. So you'll find many here if you're looking for one that's relevant for your organization. And what we want to know when we use a PDA is that they are of high quality. And for this, there is an International Patient Decision Aid Standards, or IPDAS. So there is a link to this explaining what are some of those standards, the criteria, what makes a good patient decision aid. And then in terms of databases, you'll find one again from the Ottawa Hospital Research Institute and also from NICE, again, the National Institute for Health and Clinical Excellence. And both of them follow these international patient decision aid standards. So a way of finding these, and I've just got on the screen here one on statins. Should I take statins? And again, a patient decision aid is going to describe the options, whether to take or not to take, and use that again as a tool to support the person in making decisions regarding their care. So one comes from OHRI and the other from NICE, but again, both are IPDAS compliant. If you are unable to find a patient decision aid, there also is an Appendix M, a decision guide template that allows you to use it for any decision that a person may be faced with. So while there are many on those two databases, you may be looking for a generic template, and this one is linked in the BPG and is also available in a number of different languages. And again, walks through the process of shared decision making, some of the considerations, and can be a helpful tool to help a person or substitute decision maker to make decisions pertaining to their care that align with people-centered values. Now, we want to build capacity in using this tool. Again, remembering the tool does not do the job. We have a job to do in terms of facilitating shared decision making, and having educational resources that are linked in a BPG can be very helpful. So we're not having to create our own educational resources. And we know that for many organizations, they use education as a key implementation strategy. So again, from the Ottawa Hospital Research Institute, they have a video that's linked in the BPG on decision coaching. So it's using that fillable template that we saw in the previous slide and walking through what is this process of shared decision making and how to use the tool most effectively. And again, this can be helpful for staff to review. There also in the BPG is Appendix C. This is the education statements. And we include these in the BPG, in any BPG where we do not have a recommendation statement specific to education. And this describes then in these two statements what are best practices in terms of advancing evidence-based practice using education strategies. So one statement pertains to students and one pertains to providers. So again, these are not specific to the PCC BPG, but can be helpful in the implementation of this BPG and understanding best practices in relation to education as an implementation strategy. And again, more resources to support building capacity in using PDAs. And we know that this is largely based in communication. So we've got some resources that come from OHRI, including this decision coaching resource that gives us some suggested language. Sometimes staff need help with some of those back pocket phrases that just help them to walk them through a process and help them then to support the person in making decisions using a PDA. And finally, here's my wrap up in terms of key takeaways of getting started with implementing the PCC BPG. Again, first we need to form a change team. Someone needs to take responsibility in our organizations to be guiding, leading this change process. It will not happen all on its own, and it simply doesn't happen from staff reading the BPG. We need this change team to actively read the BPG. We need them to make sense of what is the guidelines saying and be able to translate that to staff. And then we also want them to actively read it and see all of the great implementation tools, tips, strategies, etc. that is here that can help to enhance practice. We want them then to use the online PCC BPG gap analysis template to be able to determine the no-do gap and think about where are all those opportunities where we can further enhance practice to align with people-centered care. We want to think about then in terms of the actions that we need to take in order to support practice changes. It'll be based in part on the results of that gap analysis and also what are some of the barriers and facilitators, what will be some of the challenges to making practice changes and to support staff in that. Again, consider the many implementation tips, resources, and tools available in the BPG. Again, this isn't just a summary of the evidence supporting these good practice statements and recommendations, but also includes a number of tips, resources, and tools that can really help us to think about putting this knowledge into action. And then finally, we want to make practice changes that are visible so that they are defensible. We can say we are doing them and this is how we are doing them. And also, so they are measurable. It's hard to measure something we cannot see. And so that's why the practice change must be visible. And we offer lots of insight into how to measure these good practice statements and recommendations. For that, I turn it over to my colleague, James.
Thank you, Catherine, for your wonderful presentation on the implementation of this BPG. So in this part of our presentation, we'll go over some session objectives, including how monitoring and evaluation can support structured implementation of the people-centered care BPG, as well as describe the actions to evaluate the impact of implementation. So over onto the next slide. As organizations implement this BPG, we ask you to consider how you'll monitor and evaluate their impact. To facilitate this work, the BPG is equipped with a monitoring and evaluation chart as shown on the screen. And this chart is structured according to the Donna-mediated model, which is a foundational framework for evaluating the quality of health services through three components: structures, processes, and outcomes. And this monitoring and evaluation chart contains indicators that are designed to monitor the adoption of new knowledge and practices from implementing the best practices outlined in this BPG. And navigating this chart is fairly simple. So let's revisit Good Practice Statement 2, which is participating in shared decision-making, and Recommendation 1, providing decision aids as examples. So let's say your organization is implementing GPS 2 and Recommendation 1. How do we know if shared decision-making and the use of decision aids are being adopted and integrated into practice? If we look at our monitoring and evaluation chart, the left-hand column lists out the good practice statement or recommendation, and the middle column provides a corresponding indicator. So for good practice statement 2, we can see that the indicator for this is percentage of people who participated in shared decision-making about their treatment, care, and services. And below it outlines the numerator and denominator for calculating this percentage. And you may also have noticed that there's a third column over on the right-hand side of the chart that shows whether indicators are aligned with other measures available by other organizations. And when developing indicators for the good practice statements and recommendations, we align them with existing measures by other organizations when possible. We aim to do this to reduce the reporting burden by following the principle of collecting data once and reporting multiple times. So looking at GPS 2 again, if you're collecting and reporting data on shared decision-making, it may also be something similar to what you may already be reporting to Ontario Health, for instance. And when there aren't any existing measures similar to our indicator, such as with Recommendation 1, it'll be noted as a new indicator. And if we go over to the next slide, the monitoring and evaluation chart is also designed to help you evaluate outcomes resulting from implementation. And outcomes aren't tied to a single good practice statement or recommendation, as they are instead evaluating the broader implementation of the BPG. So looking at GPS 2 and Recommendation 1 again, integrating shared decision-making and the use of decision aids, when applicable, may contribute to outcomes such as positive experiences with care and positive experiences with involvement in the planning of care and treatment. And for those organizations that are BPSOs, these indicators will be available to you on RNAO's data system called Enquire, where you can report data collected for your selected indicators. And over onto the next slide, please. Thank you. So here we have a diagram that illustrates our indicator development process, which mirrors our process for guideline development. So first, we select the guideline we're developing indicators for. In this case, it's the PCC BPG. And next, we review the drafted practice recommendations, the overall outcomes of the guideline, and previous editions of the BPG. From there, we pull out potential measures that can be used to develop indicators. And once we've identified recommendations and good practice statements, we start drafting the indicators. And these include both structure and process indicators, as well as outcome indicators that align with the overall outcomes of the BPG. This is also when we conduct that environmental scan to identify any alignment with measures existing with other organizations. Then our indicators go through two validation steps. So the first happens when the BPG is sent out for expert panel review, and these indicators are sent at the same time as the draft of the BPG, using a survey format that captures both quantitative feedback for criteria such as relevance, feasibility, usability, and readability, as well as qualitative feedback, where respondents of the survey have the option to include comments to provide any thoughts and context for the rating of the indicator. We then review the feedback and revise the indicators as needed before sending them out for external review. And the second validation step is sent to BPSOs and external reviewers, where they also provide quantitative and qualitative feedback, which we integrate as well. And after the indicators are finalized, they're published in the evaluation section of the BPG in the form of the monitoring and evaluation chart that we just covered. And we also publish an accompanying data dictionary to provide more details about the indicators and build them into Enquire for reporting and evaluation. And finally, our research unit looks at how these indicators are being used in practice, and this helps us decide whether indicators should be kept, replaced, or removed based on how well they align with the latest evidence of the PCC-BPG. And this cycle continues each time the guideline is updated. And on to the next slide, please. Thank you. So when should we start thinking about evaluation? Evaluation shouldn't only happen at the end of an initiative. Like how discharge planning starts at admission, evaluation should start before implementation, continue during implementation, and take place after implementation. And we want to monitor how the new recommendations and good practice statements are being used, and whether the changes in practice are making a difference. So some questions we should be asking are the PCC-BPG recommendations being used? Are staff actually following them? Is the implementation strategy working? And most importantly, what difference is this making to clinical practice and health outcomes? And over onto the next slide. One of the first steps after completing a gap analysis is for the BPSO lead to identify the evaluation team. And this is key when planning for NQuire, because having the right people involved helps prevent challenges later on. And the BPSO lead for NQuire is usually the BPSO lead and is the most essential member of the NQuire team. They're central to ensuring NQuire is used effectively to evaluate BPG implementation, which is why they're positioned at the core of the work closely with the rest of the team. And it's important to include people with clinical experience and leadership who understand how proposed changes will affect clinical care. So frontline staff, such as nurses and other interprofessional team members, can provide valuable feedback on how care processes are changing and what impact this has on people, since they're directly involved and often collecting the data. Senior management or a project sponsor should also be involved. They can champion the quality improvement project, secure resources, help address barriers, and use evaluation results to influence policy or scale up implementation. And it's also helpful to include individuals with technical expertise who understand quality improvement processes and health information systems. So some organizations may have decision support specialists, clinical informatics, or other IT staff who can help standardize documentation, identify data sources, and extract data from electronic medical records. And of course, not all organizations have the support and are using paper documentation. In that case, some team members may take on multiple roles in data management. And finally, include individuals who provide day-to-day leadership, such as professional practice leads to support ongoing tasks like data collection, analysis, and change implementation. But you may also find that other departments can play an integral role in your evaluation team. So for example, HR and finance department, they may have administrative data that may be useful for structure indicators. And on to the next slide. So let's talk about selecting indicators. So first, defining what you're measuring is critical because the quality of your data depends on it. And if we're implementing the PCC-BPG, we start by conducting a gap or opportunity analysis to identify which recommendations or good practice statements will be prioritized. And when choosing indicators, think about feasibility and your organization's priorities. So ask yourself, what resources do we have? Who can help us access the data? Where does the data live? Is it on paper, in the EMR, or both? And are we already collecting this data for something else, like a mandatory report for funding requirement? So wherever possible, choose measures based on data you're already collecting, because this makes quality improvement easier without compromising accuracy. And finally, consider the level of implementation. So is this being rolled out on specific units first or across the whole organization? And establishing this determines how you plan your data collection. Now I'll turn it over to our evaluation specialist, Dr. Anam Ali, who will walk us through the indicator mapping document, as well as the implementation, post-implementation, and sustainability components of our presentation.
Thank you, James. Hello, everyone. I'm Dr. Anam Ali, and I work as evaluation specialist. In this slide, we can see that there's a mapping document, which basically presents monitoring and evaluation component of the mapping document that is developed to help BPSOs transition from older guideline. The purpose of this document, actually this section, is to compare indicators and recommendations across guidelines, showing what's new, what's been revised, and what remains consistent. Here is an overview of how we can read this section of mapping document. In the first column, your left hand, you can see an indicator from the updated PCC guideline, which is percentage of people reporting an overall positive experience with care, which is aligned with satisfaction indicators in previous versions of guideline, that's 2015 and 2006, as seen in columns 2 and 4. This document will help BPSOs to understand how to adapt their current practices and evaluation strategies to align with the new guideline. Next slide, please. Here you can see an example of an outcome indicator that demonstrates how implementation and data collection can lead to measurable improvements. We have an indicator here at the bottom of the slide, which is percentage of people reporting an overall experience of care. The inquired data showed that from 2021 to 2025, the percentage of people reporting a positive care experience increased significantly, from under 80% in 2021 to over 95% in 2025, as seen in the graph. These upward trends reflect the impact of implementing the BPG and continuously monitoring the progress. It also shows how setting a baseline, defining targets, and conducting follow-up surveys can support continuous quality improvement. This kind of data is essential for demonstrating success and identifying areas for further enhancement. Next slide, please. Thank you. Identifying your data sources. When evaluating implementation of BPG, we recommend a mixed method approach, which is basically combining both quantitative and qualitative data component for comprehensive evaluation. Quantitative data might include metrics like satisfaction scores, adherence rate, while qualitative data comes from interviews, focus group, or open-ended survey questions. This approach, where you combine both qualitative and quantitative component, provides a more holistic understanding of how the guideline is being implemented in experience. It's also important to engage a diverse group of participants, including staff, healthcare providers, people receiving care, and their caregivers and families, to capture a wide range of perspective. Finally, another important component is the structured timeline for evaluation. It could be weekly, monthly, quarterly, or annually, and this timeline helps to ensure consistent monitoring and timely adjustment as required as per the circumstances. Next slide, please. Sharing your implementation data is not just accountability. It's more about learning, motivating, and improving. When staff see the positive impact of their work, it boosts morale and reinforces the value of evidence-based practice. It also helps identify challenges early, such as resource gap or communication issues, or they can be addressed proactively. Sharing success stories, whether you share it through internal reports, conference presentations at audio events, or external publication, can inspire other team members and organizations to adopt similar practices. Ultimately, this contributes to a culture of continuous improvement and better care for the people. Next slide. Post-implementation, the focus basically shifts to sustainability and knowledge translation. We need to assess whether the implementation was carried out as planned. This is called execution fidelity. We also analyze outcome data to see if goals are met and identify any gaps that need attention. Engaging people and their caregivers and family in this phase is very critical. They can provide valuable feedback on what worked and what did not work. To sustain improvements, successful practices should be embedded into the organization policies and culture. This includes securing ongoing resources, continuing education and mentorship, and sharing findings widely through infographics, social media, peer review academic publications. Next slide. To wrap up, here are the next steps for implementing and evaluating PCC BPG. First, identify your implementation and evaluation teams. As explained by James, it includes clinical lead, data experts, and frontline staff. Number 2, conduct a gap analysis to determine where current practices differ from the guideline. Number 3, select indicators, choose measures that aligns with your organization priorities and the guidelines. Number 4, develop a logic model. It maps out your inputs, your activities, your outputs, and all your outcomes, which include short-term outcomes, long-term outcomes. Then plan for standardized data collection to ensure consistency and reliability. And finally, begin baseline data collection to set the foundation for measuring the progress. I will now pass it over to Verity to begin our question and answer session.